So last time we talked about Alzheimer's dementia, and so keep that in mind as we go through the different types of dementia, and we'll see that there are always unique contrasting features here. So multi-infarct dementia is either the second or third. It's probably the second most common cause of dementia. And a difference with Alzheimer's where, you follow someone with Alzheimer's every 3 months, every 6 months, there's a decline, and it stays at about the same rate as they get worse. In multi-infarct dementia, since this is due to stroke, it has a stepwise decline. So every time the patient has a stroke, there's an abrupt drop in cognitive function, and we'll see they also have focal symptoms as well. And so these are more common with cortical strokes. So if someone's had an MCA stroke, and then especially if they have another cortical stroke, that's what we see most often in terms of cognitive involvement. And so again, it's stepwise, but usually it's not difficult to make this determination, right? Because the patient has had a stroke, they have focal findings related to that stroke. Maybe it's an aphasia, homonymous hemianopia, which is quite different, than the presentation of Alzheimer's, where pretty much things are non-focal, right? They don't have a hemiplegia or, a focal visual field deficit or an aphasia that is out of proportion to the memory loss, right? So the key thing here, and this is why you have to do a careful neurologic examination in a patient that comes in with new memory problems. Okay, you will find something focal if this is multi-infarct dementia. Now, since I said that vascular risk factors, remember epigenetics, that accelerates your risk of developing Alzheimer's, and of course your vasculopath patient is also likely to have strokes. And so frequently what we find at autopsy is that we'll find a mixture of both. The patient has evidence of Alzheimer's and they've also had strokes. So the combination of the two is especially common. Now, patients that have had a lot of subcortical strokes, and I think in previous years I have said, this is much less common than cortical strokes, and more we're recognizing now that if you have just a lot of white matter disease from just subcortical ischemia, like your patient has diabetes, the more and more of those that you accumulate, the more likely you're going to have some memory problems. And so subcortical probably should not be as diminished as much as we have in the past. So if you have a bunch of subcortical strokes, again, those patients will probably have, the lecture I recorded yesterday for Thursday morning is all on stroke, and we'll go over the different subcortical stroke syndromes, but they're going to have focal findings as well, with both cortical and subcortical. So again, when we say focal findings, we mean like a hemiplegia, an aphasia, a visual field deficit, that kind of a thing. And also, what is a classic subcortical pathway? It's the cortical bulbar tract. And so these patients, often when we do an MRI scan, we find they've got like 100 or more little subcortical areas of ischemia. And so what's happening is you're just chipping away at these vital pathways, including the cortical bulbar tract. And so these patients often have pseudobulbar palsy. And I really could use another 3 or 4 hours in this course to show interesting videos and things, but I have one of a patient who, he's had multiple strokes, and he just can't talk for more than 30 seconds without crying. And he, keeps really embarrassed. I'm sorry, I don't feel that sad. It just kind of, comes on. So remember that emotional lability, so classic with pseudobulbar palsy. Okay, and a patient that has a bunch of subcortical strokes, the dementia tends to be more of a withdrawn, depressed dementia in appearance. Patients with Alzheimer's, they're outgoing, they're telling jokes, they're, talkative. Patients that's had lots and lots of subcortical strokes, again, you might confuse them with just having depression. Okay, so here's a patient with multiple cortical strokes. Well, here's a PCA stroke. Here is a bilateral anterior cerebral artery stroke. Here's an MCA stroke. Okay, so just burden of disease. The more of these you have, the more cognitive deficits are going to be. And here's a patient. Now, if I told you this is a 25-year-old patient, you should be thinking multiple sclerosis. But if we have a 75-year-old patient that has diabetes and hypertension, this is small vessel disease. Okay, it's ischemia that affects the subcortical white matter. Okay, so this patient, one of these is bound to hit the cortical spinal tract, right? So your patient's probably going to have some hemiplegia. The cortical bulbar tract is certainly going to be affected, and so they'll develop a pseudobulbar palsy. Okay, so we have now kind of, here's a good time to bring together all the different things we've told you in this course that can cause pseudobulbar palsy. So in this lecture, multi-infarct dementia, with lots of subcortical strokes. In the Parkinson's lecture, we talked about two things that kind of look like Parkinson's disease but aren't. PSP, remember they have the vertical eye movement problem, early falling, multisystem atrophy, remember that's the severe orthostatic hypotension with Parkinsonism. So these both have pseudobulbar palsy. In ALS, remember it's a motor neuron disease. And so the cortical bulbar tract is a motor neuron pathway that talks to the medulla. And so there the neurons are degenerating, and those patients have pseudobulbar palsy. That's a classic feature of ALS. And I didn't really talk about this because we don't see this as much anymore as multiple sclerosis treatments have improved. But if you have a really bad demyelination of these central nervous system pathways, including the cortical bulbar tract, a patient with multiple sclerosis could also have pseudobulbar palsy. Question? Yeah, so why do they have the emotional lability? And that's not that well understood, really. So that's why I didn't try to go into the mechanism. Some people feel it may have to do with either a disconnect with the nucleus ambiguus or even, believe it or not, the periaqueductal gray. And so I try to explain things when we've got a good mechanism that's important for you to know. And this is just one of those things to know, but not to worry about exactly how it works. The dysarthria and dysphagia are easy to understand, right? Because there the cortical bulbar tract isn't able to talk to the nucleus ambiguus and the hypoglossal nucleus. Yeah, good question. Okay, so that's one. Another in the differential is dementia with diffuse Lewy bodies. And so certainly this became much more talked about here with the story of Robin Williams. And so his neurologist kind of described here how this is often misdiagnosed as Parkinson's disease. When I was a medical student, this condition was not described yet. It was kind of described as an atypical Parkinson's dementia syndrome. And so dementia with Lewy bodies, remember Lewy bodies you've learned about with Parkinson's disease, right? You get them in the substantia nigra. Dementia with Lewy bodies, yeah, you also get those Lewy bodies in substantia nigra, but they're found diffusely throughout the brain. Okay, so they have overlapping features with Parkinson's, but they also have overlapping features with Alzheimer's dementia. And so, which is more common here as the number 2 cause of dementia? Is it multi-infarct or is it diffuse Lewy body? It's not important, but just to recognize this is kind of our top 3 list for dementia: Alzheimer's, multi-infarct dementia, diffuse Lewy body. Okay, so how can we tell the difference between dementia with Lewy bodies and Parkinson's disease with dementia? Because that's usually our biggest thing that we're trying to determine here. And so one kind of rule of thumb is, when does the dementia begin? In Parkinson's disease, dementia, which happens in about 20-30% of patients, is a late feature. Okay, so if we have dementia within a year of the onset of Parkinsonian symptoms, the patient more likely has diffuse Lewy body disease or dementia with Lewy bodies. Okay, so dementia with Lewy bodies is diagnosed when cognitive symptoms begin at the same time as the Parkinsonism or within a year. That would be much, much earlier than we see with Parkinson's disease. Okay, but there are other unique features of this condition. One is these patients fluctuate dramatically. So patients I see with this condition, the spouse will say, you know, he'll just have days where he sits on the couch and can hardly talk, and he's just out of it. Then the next day is a lot better. Okay, so they have very significant day-to-day fluctuations, and probably if you're looking at something to jump out at you, you know, in a board vignette, it would be early hallucinations. Okay, so these are usually visual, but they can be auditory or other type of hallucinations. And so these are seen in 75% of patients. That's often just when I'm getting the history of a patient who's kind of looking Parkinsonian, that will just jump out at me. If they're having hallucinations, it makes it more likely Lewy body dementia. Now remember, patients with Parkinson's hallucinate, but they only hallucinate when you give them dopamine medications, right? So here the hallucinations are an organic part of the disease process, right? So they have motor features of Parkinsonism, and remember it's a synucleinopathy. So the three conditions that are synucleinopathies, remember Parkinson's disease, multisystem atrophy, diffuse Lewy body dementia. And so all three of those are associated with REM sleep behavior disorder, but this is extremely common in diffuse Lewy body, probably the highest rate of this. Okay, so if you follow patients that have REM sleep behavior disorder over like 20, 30 years, the likelihood that they're going to get one of those three conditions is very high. Okay, so the Parkinsonism tends to be milder than what we see in just regular Parkinson's disease, so they don't shake quite as much. They're a little more likely to have earlier orthostasis, so passing out. These patients are exceptionally sensitive to any dopamine blocking medications. Now remember, you don't want to give those to someone with Parkinson's either, right? But if these patients get even a single dose, they're just incredibly incapacitated by this. So super sensitivity, really, to these types of medications. And 10%, I mean, this seems more common in my just anecdotal experience, but 10% may have Capgras syndrome. Have you learned about that yet? So this is where, you know, you have a married couple, and the individual with this becomes convinced that their spouse is an imposter. It's not the real individual. It's not the real person that I married. And so this is very distressing, obviously, but it's just a fixed belief that they will have. And I've seen this a number of times. And, you know, it's, again, a loving relationship for many decades. And then the individual just, you know, they lose trust. They think it's not the real person. Someone else has inhabited their body. It's kind of a strange delusion. It's not specific for this condition. We can see it in some other neurologic conditions, neurodegenerative, but it's something that we can sometimes see. Right, so the Lewy bodies, remember, are not confined to the substantia nigra. You find them throughout the brain, so at autopsy we can confirm the diagnosis. They're otherwise similar, and again, you affect the substantia nigra, so that's why you get the Parkinsonism. But you also have a dropout of these areas in the basal forebrain, like the nucleus maynard, that make acetylcholine. So you can kind of think of diffuse Lewy body as a mixture of Parkinson's and Alzheimer's together, right? That's why the dementia is an early feature of diffuse Lewy body. Okay, if you do an MRI scan, you're not going to find anything that is specific for this condition. Okay, so that's at autopsy. But they are going to have atrophy of the brain. And, you know, I guess in contrast with Alzheimer's, you're less likely to find the neurofibrillary tangles. Okay, so just a reminder what a Lewy body looks like. You need to be able to recognize that. Treatment of this condition is very, very challenging because let's say you want to give a dopamine medication to help with their tremor and Parkinsonism. Well, what do those medications cause? They cause hallucinations. What does the patient already have? Hallucinations. And so treating the Parkinsonism is really difficult. So I will, you know, if I'm going to use like a carbidopa, levodopa, really low dose, very careful. You let me know at the first indication that you're having more hallucinations. You cannot give for the hallucinations and the some of the delusional thoughts, you can't give the dopamine blocking medications, right? Because they're super sensitive to those. And so we'll use the atypical neuroleptics, and quetiapine is just one that neurologists like to use a lot because it doesn't have that much effect on dopaminergic pathways, so it's more gentle for these patients and would be a good choice. If the hallucinations are really distressing, we would use quetiapine. And I told you that there are several acetylcholinesterase inhibitors for the treatment of Alzheimer's dementia. And I mentioned donepezil is the one that I think I've only seen asked on boards. But rivastigmine, for whatever reason, maybe it's just more studied, but it's considered kind of the first-line treatment for diffuse Lewy body dementia. So it can help with the cognitive and can even help with some of the behavioral issues as well. Okay, so again, Parkinson's disease with dementia, 20 to 30%, maybe 30 to 40%, but it's a late feature, okay? But clearly when someone has Parkinson's, they are, compared to, age-matched population, about 4 times more likely to have a dementia. And as I mentioned in the lecture on Parkinson's, that makes it a real challenge to treat the Parkinson's, because they're you're going to worsen the delusions and hallucinations that go along with the dementia. Makes it a real challenge. Okay, frontotemporal dementia is our 4th most common cause of dementia. And so one key feature here is that we have an earlier age of onset. And in fact, in some studies, if you have a patient with dementia under the age of 65, frontotemporal dementia is about the same in incidence as Alzheimer's. Okay, so an earlier age of onset. And so as the name indicates, the atrophy occurs in the frontal lobe and the temporal lobe. Okay, so we have focal atrophy, and that's something here an MRI scan really would be helpful to make a specific diagnosis. Okay, so it does overlap a lot with Alzheimer's, but the earliest symptom in frontotemporal dementia are more behavioral, psychogenic. Okay, in Alzheimer's, it's the amnesia, the forgetfulness, the short-term memory problem. In frontotemporal dementia, it's usually a distinctive behavioral change. Okay, now if the atrophy of the temporal lobe happens to be on the dominant hemisphere, now you have a patient with a progressive aphasia, and this is especially common involving the left temporal lobe. So you can have someone that looks like a Wernicke's aphasia, but it's not coming on suddenly like an MCA stroke, it's coming on gradually. Okay, so the behavioral variant of frontotemporal dementia is at least half of cases. And so these patients are classically disinhibited, and so they lose that filter. They say whatever comes to their mind. They often make inappropriate comments. And I've seen this so often in patients who I go out to the waiting room to get them and walk them back in, and they make an inappropriate comment about the nurse or the medical student who's working with me. That happens just all the time. And for me, that's a clue. Okay, this is something's probably going on here. Remember that the frontal poles, especially, when we have a problem there, the very tip of the frontal lobes, then patients lose empathy. And so I ask about that, and there frequently will be a story about something that happened, a friend, a family member, and the patient just didn't seem to care that much. So that's a classic feature. Hyperorality, especially for sweets, is really common, and so patients will just have, it's usually one thing that they develop a fixation for. I don't know, M&M seems to be the most common one that I've seen. And they start gaining weight, and the spouse needs to lock it away, or it becomes a big deal because they just keep consuming one specific sweet. And compulsive behaviors are really common. So I've had patients just fixated on a stamp collection, or a patient I saw not too long ago. Every once in a while he would go to the beach with one of those metal detectors, and now that just became all he wanted to do and all he could think about and all he could talk about. And so it's often those kinds of things. It can, take the form of obsessive hand washing or door lock checking, that kind of thing. But it's often a hobby or something that they just become overly focused on. Okay, up to 20% of patients can have motor neuron disease. And so I'll just remind you here in the spinal cord lecture when we went over the genetics of ALS, and that this is really the important one to know. And it's too bad they gave it such a difficult name to remember here, CNORF72. But that mutation in terms of ALS is responsible for almost half of familial ALS and even in 5 to 8% of sporadic ALS. So we can check this in our ALS patients, but this is the one that has overlap with frontotemporal dementia. Okay, and so ALS doesn't tend to have, in most patients, really overt cognitive effects, but if you really do formal cognitive testing, you often will find some cognitive or behavioral problems if they have this mutation. Okay, so we want to associate that here as kind of an overlap syndrome between frontotemporal dementia and ALS. All right, so if we do an MRI scan, we're looking for focal atrophy, and here at autopsy you can see, just look at the large sulci, small gyri here in the frontal lobe. So if you see something like that, focal atrophy, it's most likely frontotemporal dementia. And I'll let Dr. Deich go over the neuropathology, but it kind of looks like a mixture of Alzheimer's and Parkinson's as kind of a nutshell. Anytime we have something that involves a lot of the frontal lobe, we'll look for those frontal lobe release signs, right? The glabellar sign, the grasp reflex, the snout reflex. So those would be common with frontotemporal dementia. All right, so now we have been through, and I told you I'd let Dr. Deich talk about the neuropathology, but this is a tauopathy. So now if you can, I think, know these 3 synucleinopathies and 3 tauopathies, I'll be happy. So the synucleinopathies, Parkinson's, MSA, dementia with Lewy bodies. So remember, all 3 have REM sleep behavior disorder. The tauopathies are PSP, Alzheimer's, and frontotemporal dementia. Okay, and the literature in neurology is now, so much focused on the protein abnormality. So we really do use this terminology quite a lot. So here's just kind of I made this table as a way to try to remember our 4 most common causes of dementia. So in terms of onset, remember frontotemporal dementia, it's the earlier age of onset. That's a clue. The first symptom in Alzheimer's is memory loss. In frontotemporal dementia, it's a personality change. In Lewy body dementia, remember they have dramatic fluctuations. They have hallucinations. Because it's a synucleinopathy, they have REM sleep behavior disorder. And in multi-infarct dementia, you have focal findings that relate to the strokes. Okay, most of these tend to progress in kind of an insidious manner. Lewy body, remember you have the big fluctuations, but in multi-infarct, it's a stepwise with each stroke. Okay, in motor symptoms, remember we get all these apraxia with Alzheimer's. Frontotemporal, because we have such profound frontal lobe involvement, our most dramatic frontal lobe release signs will be seen there. We have Parkinsonism with Lewy body dementia. We have focal weakness with multi-infarct dementia. Okay, and when we do imaging in Alzheimer's, they're all going to have atrophy, but in Alzheimer's, we especially see hippocampal atrophy. In frontotemporal, it's atrophy of the frontal and temporal lobes. In Lewy body, we just kind of have generalized atrophy. In multi-infarct dementia, you'll see strokes. Okay, and then here is just a little bit of what we'll see here at pathology. Remember the neurofibrillary tangles, senile plaques. We're going to see tau in frontotemporal dementia, alpha-synuclein Lewy bodies, and we're going to find lots of plugged blood vessels in a multi-infarct dementia. But despite all of our best efforts, sometimes the patient goes to autopsy and we're surprised to find out, they had a dementia syndrome that we didn't think they had. So we make it seem black and white here, but oftentimes there's overlap between these conditions, which makes it difficult. So I'm not going to go over Huntington's disease again because we went over this in the movement disorder lecture. I just want to have you put it here in the dementia lecture as well, right? Because part of the triad for Huntington's is dementia. Okay, but here you shouldn't confuse this with the other dementia syndromes because you've got an autosomal dominant family history, you've got the choreiform movements, so quite distinctive. Remember that it starts out as a quick, choreiform movements, but late in the course they become kind of Parkinsonian. And don't forget the caudate atrophy in Huntington's. Okay, and I showed you an MRI here, no caudate nucleus. Okay, so that's your clue. All right, so next week we will talk about HIV and the neurologic complications. And so this is something that I'm not going to talk about now. I'm just wanting you to have it as a category here in dementia, that patients with AIDS as a late manifestation can have this HIV-associated dementia complex. And at that time, I'll tell you, whenever someone with HIV presents with memory problems, we do a big workup, MRI, lumbar puncture, the whole thing, because there's so many treatable causes of this. If they have this HIV dementia complex, this is not treatable. So we rule out all the infectious things, and then if that's all normal, then this is our diagnosis. Okay, so here's a very important high-yield board question, even though this condition is literally a 1 in a million diagnosis. So it's quite rare. We've had 3 cases at the VA in just the last couple of years, so that's unusual. But JAKOB-CREUTZFELDT disease, and you'll see people will call it CJD or just Jakob disease. Okay, and so I'll just share some trivia here about the name. The 2 neurologists, I believe, that described this, Dr. Jakob and Dr. Creutzfeld, 70 years ago, something like that, described patients with a rapidly progressive dementia. And so it turns out you can go back and look at the brains that are still preserved of those patients that they described, and only Dr. Jakob's patients actually had the prions that are classic for this Jakob-Creutzfeldt condition. So for decades, this condition was known as Jakob's disease. Okay, and then I think in the 80s there was a researcher at NIH whose initials just happened to be CJD. And he said, wouldn't it be cool if the condition had my initials? And he started calling it Jakob-Creutzfeldt, or Creutzfeldt-Jakob disease after his own initials. And then someone, I think after his death, discovered, what he had done. And so, anyway, it's kind of interesting. So you'll just see it in different ways, and it doesn't really matter. So this is a rare condition, usually a younger onset patient. And so the biggest feature of this condition is a rapidly progressive dementia. So these patients usually die within 6 months. Okay, that is completely unlike the other dementia syndromes that we've talked about. So an extremely rapid progression. And just a very helpful clue is these patients have myoclonic jerks. So when you go in to see them, they're shaking. It's not a seizure. In the next lecture, we'll talk about myoclonus that is epileptic. And these are very responsive to stimuli. And so you may see neurologists do strange things at the bedside in these patients. We'll clap our hands or make a loud noise. And that will cause the patient to have just a whole body jerk. Right? Myoclonus, we've all had myoclonus, like when you're falling asleep, every once in a while your whole body jerks and it's very alerting. That's myoclonus, but that's a normal type of myoclonus. So myoclonus can be seen as an abnormality in certain conditions, and this would be one of our hallmark conditions, Jakob's disease. And this condition tends to involve cerebellar pathways, so they have a lot of ataxia. Okay, so that's our triad for this condition. Again, death usually within 6 months. So this condition is a prion disease, which means a proteinaceous infectious particle. Okay, and it causes a spongy degeneration of the brain, as Dr. Deich will describe to you. Okay, and so prions can exhibit in 2 states. So the normal state is present in healthy cells. So we don't want to just say, hey, prions are bad. The problem is when prions get misfolded. Okay, so prions normally probably have a role in transmembrane transport and signaling. Okay, but when it takes an abnormal folding form, it causes this exponential misfolding of all the other prion proteins, and that leads to neuronal death. Okay, so here's a drawing a medical student did to try to help you here. So we have these normal prions here in green. Okay, but when we have the abnormally folded proteins, it ends up converting the normal prions into the misfolded prions, and so eventually these just take over the cell, and then it moves on to the next neuron. Okay, so we think here what happens is you have these normal prions and abnormal prions. The SC here is for scrapie, which is a prion disease in sheep. And so it's felt that there's an intermediate form here, we'll just call it protein X, where the normal and the abnormal prions come together. This is the theory, anyway, with prion diseases. And then that leads to 2 abnormally folded prion proteins. And from 2, we go to 4, and then to 8, and then to 16. And so we have this just exponential growth in terms of the number of prions. Okay, so we have someone with a rapidly progressive dementia, and several things here can be really helpful to make the diagnosis. First, we can do an EEG, which is in our next lecture, or in the 3rd hour, I guess. And we get these kind of bursts of abnormal electrical activity on the EEG, which is suggestive of this condition. We always do a lumbar puncture in these patients, and there are 2 things that can be really helpful in the spinal fluid. One is we look for a protein, the 14-3-3 protein, which is probably still going to be the one that boards are going to ask you about, but in recent years there's a much more sensitive and specific test called an RT-QUIC test, okay, which is extremely helpful for making the diagnosis. So this is usually how we confirm what the patient has. Now if we do an MRI scan, we often get signal changes in the basal ganglia. So here's the caudate, here's the putamen out here, and so that's probably the explanation for the myoclonus these patients have, the movement disorder. All right, but another even more classic feature on MRI scan is known as cortical ribboning. Okay, and all of the last 3 patients we've seen recently had this kind of pattern. Okay, it just outlines the cortex. So this is quite a specific feature for JAKOB-CREUTZFELDT disease. So we see this in a patient with rapidly progressive dementia. So we have lots of ways really to make the diagnosis quite accurately in these patients. So overall, the sporadic form, that's all that I've ever seen, where it's just sporadic that makes up to 95% of patients. There is a familial form of this. Well, and I shouldn't say that, because I have seen one individual that had a family history of this. And so you can have a prion gene mutation that's autosomal dominant. Okay. Idiopathic, although this still may be asked on boards, these are almost have been eliminated in the last 15 years or so. But going way back, there are cases of JAKOB-CREUTZFELDT that have been related to growth hormone or dural grafts, corneal transplants, or even receiving IVIG infusions. But I don't think there have been reported cases of that in a long time. Of course, what everyone is worried about is the variant JAKOB-CREUTZFELDT disease, the mad cow disease that can involve humans. And so these are often younger individuals, and it has a little bit of a different presentation, but it still is with a rapidly progressive dementia. At least up until a year ago, I haven't checked things more recent than that, but all of the cases were in individuals that were in England or France. There were a few individuals who were in England and France that came to America and got it, but we think it came from England and France, and of course most of the mad cow disease has been from over there. Now this was kind of a shocking study a few years ago where they looked at lymph node biopsies in people in England, and 1 in 2,000 had the abnormal prion protein in their lymph system. And no one really knows exactly what that means, but just a concerning thing here, not to kind of be an alarmist here, but a form of prion disease called Kuru, which is due to cannibalism, like in New Guinea, where up until, I don't know, the 50s or 60s, it was still a ritual to eat the brain of the deceased family member to kind of, internalize that person. That this would lead to a prion disease. It looks a lot like JAKOB-CREUTZFELDT disease. We call it Kuru. But the incubation period was decades. So it took a long, long time after that to develop any features of the prion disease. So anyway, just remember that next time you're having a McDonald's hamburger that, at least theoretically, we don't know how long, but we do know it's a long incubation period. All right, so Korsakoff syndrome. We talked about Wernicke's encephalopathy, okay, and so this is the sort of the manifestation of untreated thiamine deficiency. And so, more often in your alcoholic patient who comes into the emergency room, they're given thiamine. Remember, the triad for Wernicke's encephalopathy is an eye movement abnormality. It often looks like a bilateral 6-nerve palsy, but it can literally do anything. All right, so it's a patient that comes in normal, they're given IV glucose without thiamine, and they have a severe eye movement problem. They become confused, and it tends to affect especially the midline of the cerebellum, and so they have a pretty profound gait ataxia. Right, so that's our triad of Wernicke's. That's why you always give, patient comes into the emergency room, you give thiamine with the IV glucose. Now, if we don't recognize this condition, and they just have this kind of prolonged thiamine deficiency, then they can merge into Korsakoff's syndrome. And so Korsakoff syndrome, we talked about, I guess, in the memory disorder lecture, but it's important enough just that I remind you of it here, is unique in that almost all the different types of memory loss occur from whenever the neurodegenerative process began and then going forward. And they have relatively preserved remote memories. Korsakoff's is one of those where patients have severe retrograde memory loss. So they have huge pockets of old memories that are not present. And so remember then, because of that, they fill in the gaps. And so they confabulate. They make up stories about their past. So these patients tend to be pretty alert, attentive, just like a patient with Alzheimer's, right? They're not sleepy, confused. They don't have insight, just like a patient with Alzheimer's would not have insight. But the confabulations, and if you ever get a board question on Korsakoff's, you're going to see confabulation here as part of it. So invented memories. All right, and remember that, how do we diagnose Wernicke's encephalopathy? Well, you do an MRI scan. Remember, here are the mammllaries right here. They're just ventral to the midbrain. So here's the midbrain. I wish the arrows weren't there. It kind of obscures everything. But here we have these signal changes right here in the mammillary bodies. So you're not going to find that in someone, years down the road that has Korsakoff's. This is the acute finding in Wernicke's encephalopathy. And this does help to explain the memory loss, right? Because mammillary bodies are in that Pape circuit loop. All right, normal pressure hydrocephalus. I could not possibly overemphasize how uncommon this condition is. All right, but I'm just going to say that up front. But yet, it is on every time I'm allowed to review a board or shelf exam, it's there every single time, which is very annoying. Okay, because they'll choose to ask this over a question on migraines or something like that that's really common. So you need to know this, but please, don't diagnose this a lot when you're physicians, okay? I have maybe seen 2 patients in almost 25 years as a neurologist that I really thought someone had it. So it's very common, and the big problem with normal pressure hydrocephalus, the reason it's overdiagnosed, is we could not come up with a more non-specific triad than this. Okay, so we have a patient that has a walking problem, they have dementia, and they have urinary incontinence, which is a triad almost every Alzheimer's patient will have, right? So they're going to be a little unsteady because, you know, you're older and you've got maybe orthopedic issues, maybe you've got some neuropathy, dementia can contribute to gait instability. It's just common to be a little unsteady on your feet with age. So it's an extremely nonspecific triad. Now, classically, if someone really has normal pressure hydrocephalus, this is what you'd like to hear. It starts with a gait problem. Okay, we call it a gait apraxia. It's not due to weakness, but it's a loss of the motor program in the brain that allows your legs to just automatically move when you walk. And so this is the first symptom. And this tends to mainly be a problem with gait initiation. So when the patient stands up to walk, they just can't get the feet going. Once they start walking, then they can actually improve. So that's the first symptom. Then they have some dementia, and they may have some urinary incontinence. And most patients that we think have it don't even have the full triad, just to complicate things further. But if you see this on a board question, get the right answer. Go choose normal pressure hydrocephalus. But remember when you're circling that answer that in the real world, I'm not going to think this patient has normal pressure hydrocephalus. So they can have some features of Parkinsonism, which, again, to add further fuel to the overdiagnosis, there was a big news feature on some popular TV program suggesting that lots of patients have been misdiagnosed with Parkinson's. They have a very treatable condition, normal pressure hydrocephalus, which has led to lots of patients coming, thinking that they might have it. And so the idea in normal pressure hydrocephalus, there may have been a time where the CSF was under increased pressure in the ventricular system that caused the lateral ventricles especially to dilate. But then by the time we see the patient, it's under a normal pressure situation. So you have enlarged lateral ventricles. So why do they have a gait problem? Well, the motor fibers from the leg have to loop around the lateral ventricles on their way down. And so if you have this kind of enlargement of the ventricles, it affects especially the leg fibers. So that's why they have a gait apraxia. And remember, the paracentral lobule is also for the bladder as well. And so those fibers that go with the bladder travel right with the leg fibers. And then just if you have something here, involving the frontal lobe, there will be some dementia as well. So in terms of theories, it might result from a failure of the arachnoid granulations to resorb CSF. Okay, and so it's a communicating hydrocephalus, not a non-communicating hydrocephalus. Ventricles push forward against midline pathways. Okay, and so another reason it's overdiagnosed. So remember, we've got a non-specific triad, but this is an issue. When you do an MRI scan in an older individual, almost always the ventricles look a little big. There's a little bit of atrophy, even with normal aging. And so that is usually hydrocephalus ex vacuo. But oftentimes, radiologists maybe will say, can't rule out NPH, which then leads, to a neurology referral. Sorry if I'm appearing sensitive about this issue. It is something that comes up every week, literally. So now in true normal pressure hydrocephalus, we really don't see any cortical atrophy. So here's, at this level, a pretty normal CT scan. Here we have big ventricles. Now here it's more obvious than most that we have a lot of peripheral atrophy. Look at all the big sulci here, the big Sylvian fissure. And so does this patient have normal pressure hydrocephalus? No, clearly this is atrophy. Okay, but it can be hard. A CT can overestimate the amount of ventricular enlargement relative to the peripheral atrophy. And so that's why the neuroimaging is not really straightforward in this. Now here we clearly have big ventricles, but no atrophy. So this patient has hydrocephalus. We don't know the cause, but yeah, this is something, if it fits in the right clinical pattern, could be normal pressure hydrocephalus. So just as an idea to tell you how uncommon this condition is, It was a really good autopsy study, 563 patients who had dementia. They were all followed and diagnosed by neurologists. And you can see only 9 out of those 563 were felt by neurologists to really have normal pressure hydrocephalus. But when those patients went to autopsy, 8 of them had Alzheimer's, and the other one had progressive supranuclear palsy. So in 563 patients with dementia, probably not one actually had normal pressure hydrocephalus. And so when you see someone that's wobbly on their feet and they have big ventricles, most likely this is the onset of a neurodegenerative process like Alzheimer's. Okay? And so the idea here is also often, well, why don't we just put a shunt in and see if it helps? And the issue there is about up to 40% have an infection of the shunt. And, so it's not just a benign thing to do. There's also no benefit that the shunt helps beyond maybe 18 months, even in a true case of NPH. So something that we are often asked to do is to do a lumbar puncture, a high volume lumbar puncture. We take out like 40, 50 cc's of spinal fluid. It's really just let it all drain out. Not all, but a lot of it. And so the idea here is you remove a lot of cerebral spinal fluid, which is then going to take pressure that those lateral ventricles were exerting on the motor fibers, and then you watch the patient walk after the lumbar puncture. And if they walk a lot better, then maybe that patient would be a candidate for having a shunt placement. So that is one kind of objective test that we can do to evaluate for normal pressure hydrocephalus. And again, even when I think someone really has normal pressure hydrocephalus, it still is not a slam dunk to shunt those patients because the shunting doesn't seem to last for too long. Yeah, and risk of shunt infection. Okay, so I wanted to just go over one last condition here, and that is pseudo-dementia related to depression. So it should be a little bit of a red flag when a younger individual is referred for memory loss. Because remember, that's not common unless we've got like familial ALS or something rare. It's not very common. Yeah, frontotemporal dementia might creep into mind, but if you have a young individual that's having memory issues, it often is related to depression. And so how do we diagnose that? Well, again, age of onset should be a clue. So younger individuals often. And unlike Alzheimer's, the onset and course can be abrupt. And so I'll never forget a patient I saw who wanted to see me for memory loss, and it began at her friend's funeral. When you talk with patients that have other neurodegenerative conditions and you talk with a family member, the onset is kind of vague. Well, I think it's been about 5 months. There isn't like one moment in time when it began. It kind of comes on gradually. And there often is dramatic fluctuation, so some days I can't even remember my own name, and the next day I'm fine. That's kind of unusual. When we do cognitive testing, often there's poor effort, and they emphasize failures. So if maybe there's 1 point missed on cognitive testing, the patient, may become very emotional and say, you see, and, unlike someone with Alzheimer's, they're trying to put their best foot forward. They're trying to deflect. They don't want to show that they have any memory problems. They're emphasizing their successes, not their failures. Exactly the opposite. So if you have a sad and teary patient with some personality changes, that would make you more likely think about this. Okay, in most of the neurodegenerative conditions, patients do not have insight. Okay, it's the family members that are concerned. And so when I'm seeing someone, again, often a younger person for memory issues, I'll ask, well, is anyone at your work concerned about your memory? Is your family concerned about your memory? And so if the patient is the main one who is concerned and recognizing it, that would be a point in favor of a more depression-related memory loss. And it can be really helpful to do formal cognitive testing in a more difficult case. And this takes hours and hours of just really going through every area of memory When you do this in neurodegenerative conditions, the findings are very consistent. You know, someone is always going to have a problem with working memory to about the same degree, and so on. These patients will often have things that are not reproducible. They're inconsistent. One time they'll perform very poorly in an area of working memory, and then you come back and test it later and they do fantastic. So you get kind of incongruity there. Okay, so as a last thing here, just to kind of finish this off, I wanted to show you a video.